Welcome to Fuller Butz, a behind-the-scenes plastic surgery podcast. Yes, you heard that right. Join your co-hosts, Dr. Sam Fuller and Dr. Dan Butz, board-certified plastic and reconstructive surgeons, on an exclusive full-access pass into the world of plastic surgery. Combining their expertise and training, Doctors Fuller and Butz will share medical insights, detailed explanations, and lighthearted humor to keep you entertained and informed. We're certain you'll become passionate about the plastic surgery specialty, and between debunking myths, uncovering truths, or just making you laugh out loud at their perspective on this creative and artistic field, we've got something for everyone. From tummy tucks to Botox and mommy makeovers to surgery do-overs, the Fuller Butz Podcast will surely satisfy your podcast fix. All right, now let's dive into this episode.
Hey there, welcome back to the Fuller Butz, a behind-the-scenes look at plastic surgery podcast. I'm here today with my co-host, Dr. Sam Fuller. We've had a lot of exciting guests on this season. We're really enjoying kind of bringing in new upbeat energy and different perspectives in plastic surgery. It's been pretty fun.
Yeah, I was just talking to a case manager from work comp last night and just speaking about Fuller Butz Podcast and the name origin. And, one of the case managers, asked me, do you have enough content for a podcast just on plastic surgery? And I was, overwhelmingly, yes, there's so much to talk about, whether it's just hot topics and different parts of the body and just, plastic surgery is so all encompassing. But the fact that we're bringing, legit experienced experts in different facets of plastic surgery is really what makes this over the top. I've learned so much about whether it's hair transplantation, the microsurgery, refreshers, and med spa details. And so it's been an awesome season. The guests have been tremendous, and unfortunately no guests this week, but we do have an interesting topic. Dan, what have you been up to? Any recent meetings or travels?
Yeah, so I just recently got back from a master's course in breast augmentation that was sponsored by a company that I tend to use for breast augmentation. But they brought in a lot of, masters in breast surgery who've been doing this for 20, 30 years to try to, again, learn new perspectives, get some pearls. And it was a good meeting. I feel like a lot of these meetings we go to, you kind of hear a lot of the same talks. There was some new perspectives. I think a new kind of trendy thing lately has been, we term subfascial or kind of muscle preservation augmentation. So I was kind of curious to hear what some of these, people who've been around the block for a long time, when people used to be doing a lot of more of this back in the 90s, to going back to more below the muscle. I thought it'd be interesting to kind of, again, not just scratch the surface of breast augmentation, but kind of dig a little bit deeper into some of these different options and why and who's a good candidate and all of that. So Sam, maybe you can kind of, just get into the kind of nitty gritty of what we're really talking about in these different planes, what that really means. The terminology can be confusing. Subfascial, subglandular, submuscular, dual plane. Can you kind of explain to our listeners a little bit about what all of that means and if it matters?
For sure. The semantics and wording can be very confusing. There's different profile implants. There are different placements of the implants. There's different types of cohesiveness. So just lots of layers of confusion, but also marketing ploys versus just facts. And so we'll try to just, keep things to the basics and start with the refresher. And, these are topics and points that I bring up to my pre-op patients for breast augmentation. So essentially, when you're talking about an implant, we talk about where the incision is going to be, what type of implant it is, and then really a large part of the conversation is where the implant is going to be placed, which is the topic of today's episode. So an implant can be placed in a variety of locations within the breast tissue. It can be placed from superficial to deep in an area called the subglandular tissue, or an area or space that's directly behind the skin and the breast tissue. So it's an over the muscle, over the fascia, but underneath the breast tissue. And I'll quiz you, Dan, or maybe you can update our listeners as far as who would be good candidates for each, but that's just essentially the definition. So subglandular, or over the muscle, is a space used that's directly underneath the skin, the breast tissue. Another plane is, and which is gaining more popularity, hearing about it a lot more, is the subfascial approach. And that is the layer of tissue called the fascia, connective tissue, that sits directly above your pec major muscle. So if you're going sub, you're going below breast tissue, below the fascia, which sits and is adherent directly onto that muscle. If you've been in a butcher shop, you've seen a pork tenderloin, something like that, you've seen that shiny, glistening layer that's very thin and that sits directly over the muscle. That's essentially what fascia is. The subfascial technique, is trending for different reasons. It's not a novel idea. It's not something that's fresh and brand new. It's been around, but it's just gaining a sort of a renaissance, and we'll get into the nitty gritty of that. But that's essentially a subfascial. The next layer is submuscular. So going underneath the breast tissue, underneath the fascia, underneath the muscle, really keeping the muscle and fascia attached all as one layer, and placing an implant that's underneath the muscle. And that's really between the muscle and then the rib cage. So there's intercostal muscles that are ribs, and you place that in the deepest space. In order to access that, you need to release some of the muscle in order to create that subpectoral pocket. And that's typically the inferior muscle insertion points and some of the inferior medial pec major muscles that are inserting against your sternum in that medial portion in the lower portion of the breast. When you talk about submuscular, it can be either completely under the muscle, which traditionally, if you're thinking about it logistically, is not really a thing for breast augmentations, at least not these days. In training, in our practice, Dan and I both at the University of Chicago did some all submuscular or total muscle coverage for tissue expanders and implants in the setting of a breast reconstruction following breast cancer and mastectomies, where we would have to actually elevate some of the serratus muscle off the side of the abdominal or the chest wall, as well as the muscle. But that's not really a thing in the breast augmentation world, just based on morbidity, pain, and just lack of evidence that that's superior. A dual plane approach is something that is, in some sense of the word, always used in a under the muscle type of technique. A subpectoral pocket is going to have that muscle is elevated and stretched, and although the implant is primarily covered by the muscle in the upper middle portion of the breast tissue, inferiorly that muscle is riding up or sitting up, and that's what is called a dual plane, because some of the implant itself is not completely underneath the muscle, and you can determine what type of plane just based on how your dissection is. Are you going to elevate the breast tissue off of the muscle minimally up to the nipple, above the nipple? Like, how much are you going to try to change the push-pull, the stretch of the breast tissue as it's lifted, as it's stretched, while the muscle is used as a covering for the implant? So dual plane, to me, I think about as a submuscular technique underneath the muscle, with varying degrees of dissection of breast tissue off of that muscle layer. And so before I confuse our audience anymore, I want to do a fact check and any fake news or corrections that you need to make for me, Dan.
No, that was spot on. And I think at the meeting, there was a lot of debate about this subfascial layer, and that sometimes you go in and it is thick and glistening, and sometimes you go in and it's paper thin, and it often kind of peters out the higher up you get. So it's not, a lot of surgeons are like, saying this is consistently a really good coverage is kind of misleading and kind of confusing. And really, we should just be kind of simplifying this as, either pre-pec above the muscle or sub-pec, kind of, again, like you're mentioning, almost always dual plane. A total muscle coverage or almost complete muscle coverage does not work very well because the implant sits too high, it's too tight, it's too painful. It's not a good approach. So really, there's really only two different placements in all practicality, and we should really simplify it for our patients and for making sure we can study this properly. That was a great overview.
Thanks. Do you want to take our listeners through some of the pros or advantages of why someone or some surgeon may want to place the implant over the muscle, whether it's in that subfascial or subglandular pocket?
So the main argument to go above and benefits that are being made and why people are moving towards this is really avoiding disrupting that pectoralis muscle. when I talk to patients about dual plane or below, I always kind of demonstrate, where that pectoralis muscle all inserts, and then we're releasing that lower portion to allow the implant to sit appropriately. The vast majority of patients are typically able to do, all activities, push up, certain pec things don't feel normal, typically not really limited. But some surgeons are arguing that, there are limitations if you're really into fitness, focused on the pec function, that you don't want disrupted at all. You should go above the muscle. And it's a more anatomic augmentation. You're going right below the breast tissue. So you're truly augmenting that versus kind of some of that augmentation being kind of hidden by the muscle, so to speak. But you need to have enough tissue to camouflage the implant. So, having that just underneath the breast tissue, if you're really thin, especially for very fitness focused people, they might not have a lot of fat tissue and probably not a lot of breast tissue if they're looking for an augmentation to hide the edges of the implant. So there's a little higher chance of visibility or kind of a step off, or again, more roundness up top with above the muscle. But again, that main benefit is not disrupting the muscle. And there is an argument that it's less painful. However, doing a lot of dual plane augmentations, a lot of those patients have very little pain, take very few pain medications. So I'm not sure how huge of a benefit that is. Did I miss anything, Sam? What are your thoughts on that?
No, maybe just review with our listeners, like if someone's really wanting the subfascial in your practice or the subglandular, something above the muscle, what are some tests or what are some ways that you examine them on the physical exam to determine if they're a candidate or if they would be at high risk for having implant rippling, exposure, kind of an obvious look, augmented look for that situation?
Yeah, historically, if you go back to the textbooks, they often will sometimes cite 3 centimeters, 2 centimeters skin pinch. And what they're saying is like when you pinch that upper pull tissue, how much tissue is kind of in between there. And it's kind of, how much tissue do you kind of grab with that? How tight do you squeeze? All those things can kind of influence that a little bit. I think with newer cohesive gel implants, we're able there, a lot of these surgeons are talking about more of like a 1.5 centimeter pinch, or really just kind of looking at the general, like, can you see ribs? Maybe that's not a great patient if you can literally see the ribs through their thinner upper tissue. And then the size of the implant probably plays a role as well. Bigger implants, higher profile implants, likely will have more roundness versus some more of the moderate or kind of low plus styles. But yeah, tissue coverage, assessing that by pinching, kind of the general exam, I think are the two kind of the main things that we're looking for to see if you're a good candidate in assessing your overall goals. Some people want that roundness and kind of more visibility as well. So taking that into consideration.
Do you promise to your above the muscle, whether it's subfascial, subglandular patients, that there will never be any animation deformity, that's guaranteed not to have animation deformity if it's over the muscle?
I don't think you can promise that because it's still sort of attached to the muscle, especially if you're subfascial. So there might be a little bit of movement. And if they flex their pecs, their breasts likely move a little bit as well. But it's a very different type of animation. And you can oftentimes, because of how we release the muscle, if you're really trying to emphasize it, you can kind of create this little border of where that pectoralis muscle used to be. Normally that's covered in clothing and not, the vast majority of patients are not bothered by that. But even with the most minimal muscle release, you're going to see, a little bit of that motion. So it's kind of getting pros and cons, likely getting less above the muscle, but not zero. Is that have you seen anything, or what do your patients say about below the muscle? Is it something that you're having patients complain about where you're looking for alternative modalities, or the vast majority of patients, I think if you're prepared for it, aren't all that bothered by it?
Yeah, when you got back from your meeting and were excited about some of the information, education you had and wanted to use this as a topic, sort of just reflected back in my practice. And I can't think of a single patient who had an animation deformity that they demanded to be corrected. And I feel like I do have great follow-up with my patients. I'm seeing them far out, and I feel like I have a good rapport where if they're having an issue, they would let me know about that. I see them, at least a year out. And so I don't see a lot of issues with the subpectoral approach or underneath the muscle approach. I always tell my patients that I like to do the safest thing. And we talked about this in previous episodes. So to me, the safest, the most detailed information and data would be, there are extremely low complication rates in the under the muscle plane. I like to use that even in high fitness people, mostly because of what you said. They tend to be very thin, have very little breast tissue anyways. And we really want to have not only limited exposure of the implants, decreased capsular contracture, infection rates, but just the natural slope. Having that pec muscle, I do feel like creates a nice natural teardrop shape in the upper pole, as opposed to that divot or that step off from chest wall to implant, whether it's subfascial or subglandular. And, we both went to the ASPS meeting last year where they, were talking a lot about their results, excitement for subfascial, and just looking at the lateral views, still felt like I can see that, that above the muscle look to it where it just didn't have as natural of a look. So, I'm not completely sold on it. But for below the muscle, haven't had too many patients at all. In fact, say that, they're unhappy with that. And I've had high fitness fanatics, coaches, trainers, people who, are, trying out and actually competing for different fitness goals and so forth with under the muscle pecs and loving them and being able to return back to full activity.
Yeah, I think that's a good point, especially like, bodybuilder, bikini models who get really lean. If you're subfascial, it just looks like nothing but implant because there's no coverage because their body fat's getting, extremely low. Some of the data, has changed quite a bit, especially when you're thinking about safety. Capsular contraction is a big thing we think about when, the traditional subglandular augmentation was thought to be much higher. And again, reflecting back on my, first 5-6 years, a lot of those really complicated revisions that I saw from, 15, 20 years out were subglandular. They're often very contracted, in odd places because they're, kind of their pockets have been misplaced, or the alternative, they have really bottomed out in the tissue, almost this rock in the sock appearance with this implant that kind of just pulled that soft tissue down over time with gravity. So, thinking about some of those tough revisions and how not to cause that, it made me kind of steer away from it because of all, older studies and whatnot. There are, again, newer studies looking at, subfascial, subglandular, whatever, above the muscle, utilizing these newer no-touch techniques has kind of leveled the playing field on CapCon. So I think that benefit has evened out now that we're using IMF incisions and Keller funnels and all these things. But not having that muscle support long term is that implant, which might look great for a couple of years, over 20, 25 years, going to slowly just sag on that skin. That's the only thing holding it up. And again, we talked about internal bras. These things can help support that, but how long, we don't have all that data yet. So I think it's again, for the right patient, it can make a lot of sense, but you just need to, educate them on what these pros and cons are, what these different, long-term results can look like, so that they're making the best decisions for themselves.
Yeah, I definitely have seen more second opinions for bottoming out in the subglandular plane as opposed to animation deformities or something wrong with the below the muscle technique. And, I think we are just question or want to see the long-term results. How are things going to be for the 15, 20-year duration of that implant? Is that going to be lasting? And internal bras, it's a mandatory addition and adjunct procedure and technique for, I think, the above the muscle in order to try to create that sling, that muscle support that's lacking if you don't have the pec muscle that's holding it in place. I think we've both seen that or agree we would be pushing for the internal bra if our patients are going to be undergoing a subfascial or over the muscle technique. Do you agree?
Yeah, absolutely. I think that's really important. I almost use it in every subfascial I've done for that very reason. So I think that, the perfect patient is, fit, but has, again, good, some breast tissue and soft tissue coverage, doesn't want a huge augmentation, and, utilizing an appropriately sized implant for their frame. So you're not going to get that big step off, but a nice taper, even with the, above the muscle, and that mesh support is kind of, can be a home run. They often, they often look very good right away because the drop and fluffing we've talked about, the Frankenboob, is often the result of the muscle, right, pulling that implant up and being tight. So the muscle has to stretch and kind of relax to let the implant settle into position. You have none of that above the muscle. So the recovery is, again, I don't think it's all that much less painful, but in theory, less painful. And is a little shorter. You still have to take similar precautions, but you can often, beat back to chest exercises at 6 weeks in the gym, not necessarily having to wait what I often recommend 3 months before you start working the chest. Most patients, honestly, when I talk about bullying, I don't really care about my chest exercises anymore because now I have breast and I'm not trying to work out my pec muscles. I can focus on everything else. So I don't know if you've had that conversation as well.
Yeah, I usually just say there's plenty of ways to maintain fitness without doing heavy, butterfly curls or trying to bring heavy amounts of weight away from your chest. If you can hold off on that for 4 to 6 months and want to go back to it, fine. But there's plenty of ways to have total body fitness without some of the maneuvers, in my opinion. We've talked about in the past that breasts are siblings, not twins, that there's differences even from one side to the other. And we've both talked offline about in the subpectoral pocket, since the majority of our cases are done that way, that there's just muscle insertion points, muscle fibers. There's variability from one side to the other as far as how much muscle is there and whether it's more medial, more lateral, and you're releasing these bands. What have you seen since you have more experience in the subfascial technique as far as the variability within fascial tissue? Is it all the same? Do you find yourself releasing more superiorly so that implant sort of fits into that subcutaneous subfascial pocket? Are there any tips and tricks that you've seen, or is every case exactly the same?
They're all very different. Creating the pocket's very different because you're literally have to make the entire thing. Submuscular, we often, open up that submuscular plane. It's this kind of loose areolar plane where you kind of can easily open it up and kind of tells you the general space, and then you modify it slightly for your implant size. Above the muscle, you can exact pocket dimensions, essentially. You don't want it too big or it moves around too much, creating every, kind of opening. Still, you want to preserve that lateral edge, and the central area, you need to be really careful. You do have a little bit easier control of cleavage because you can kind of open it up to where you want it. But it's also, that's where symastia, where the breasts get too close together. You can actually connect them in the above the muscle plane because you don't have the sternum there. So it's almost, you can do it below the muscle, but it's much harder to be kind of really, releasing too much sternal border. So it is a very different procedure and takes probably a little bit longer in all reality. But you want to just be directly under that breast tissue to create that kind of perfect glove and hand and glove kind of fit.
Does it worry you when you're doing an augpexy? So if you're doing a breast lift where you're removing skin as well, lifting the nipple if it's in a lower point in the subfascial technique as far as blood supply, or is that not as big of an issue for you?
Yeah, traditionally it was thought that the muscle kind of helped preserve blood supply to the nipple. And again, with the techniques I typically use, you kind of leave this almost central and superior medial pedicles kind of attached. But as long as you aren't making too big of a pocket, knocking out your second and third intercostals, there should be adequate blood supply. Again, really big implants, really big lift, probably, make me a little bit more nervous. But if it's, appropriately sized implant and a modest lift, I think it's still very doable and safe.
So you mentioned appropriately sized implants. Are there right or wrong implants for above the muscle techniques? Are there certain profiles that you are steered towards, or you feel like it's just each patient is unique in what you can achieve?
I think looking at each patient's anatomy, skin stretch, breast tissue is more important than a specific profile and volume number. But I think they're going to look bigger above the muscle. Probably 50, 60 cc's, almost a difference. Like it is true that you lose, going below the muscle kind of eats some volume. So you have to take that into consideration. And again, I think in trying to listen to their goals, want it to be natural. If you get a high profile above the muscle, I think it's going to look more enhanced for sure. That moderate, low plus. And I think it's the kind of same rules apply for me with a lift. Below the muscle, I like moderates better with the lift. You get high, I think it almost creates this. It's harder to keep that breast tissue long term on top of this kind of more prominent mountain versus a lower mound. You can stay there better. You have lower chance of kind of waterfall effect. Maybe not 2 years, but 5 years instead of 10 years potential, depending on skin laxity. So all these kind of long-term factors I'm always trying to take into consideration and just educate the patient about. It's always easier to make them look a little bit bigger for certain events than again the potential for gravitational skin stretch from just being too big for too long.
Do you have a different recovery plan, rehab for above the muscle versus under the muscle, or do they have the same restrictions afterwards?
It's similar guidelines. I keep my guidelines kind of loose, where it's like, generally no heavy lifting for 2 weeks, no exercise for 6. One of my things I tell everyone is like, you really need to listen to your body, be really careful early on, and then be smart the several next weeks after that. But it's kind of at that 6 week mark. So normally again with below the muscle, I'm like no chest workouts for at least 3 months. Above the muscle, can ease back into it, see how it feels, and don't go super heavy at 6 weeks, but test it out without worrying about that potentially overly stretching. You don't really want to massage above the muscle. If you massage too much, you can definitely open up that pocket, stretch things out more than you want. So you want to keep that capsule. You want a little bit of mobility in the capsule, but you don't want to stretch it out too much. So very little massage underneath the muscle. Sometimes I like to massage towards the cleavage lines to try to help soften that up faster, but never massaging lateral or down. So it's similar, but just small tweaks, which I try to just be practical about it.
For the internal bra and the above the muscle technique, where are you putting that, or is it similar technique as for the sub pec? Are you positioning it differently? Like how is that going in?
Almost exactly the same. I tend to cheat it a little bit more lateral. Instead, I've kind of been doing that more at sub pec as well. Just kind of trying to get that lateral gutter support more. I don't really worry too much about the implant going medially. But yeah, pretty much the exact same way. Just get a little gutter, lower pull, kind of hammock support.
So let's maybe rattle off.
Supports that tissue that I worry about stretching.
Let's maybe rattle off a couple of key take-home points as far as pros and cons of above versus below the muscle. So let's switch gears and have you talk about under the muscle. Like what's the biggest reason to do it or to not do it as far as breast augmentation, placing the implant under the muscle?
I think, best reasons it's going to always look more natural. I don't know why I gave that thumbs up. That's a new thing. Right. Traditionally has a lower risk, tends to stay up longer. Another thing that we didn't really talk about is mammograms. It's easier to do mammograms below the muscle than above the muscle because they can displace the implant a little bit better. And I think the other thing I used to always say is cap-con rates were lower, but that data has kind of evened out. And then the biggest con or downside is the potential for muscle animation, deformity, and a little bit, being cautious with your pec muscle early on. You have anything to add to that? Any thoughts, pros, cons to below the muscle?
No, I think that's well said. If we're going to be talking about above the muscle, pros, cons, I would say potentially the same safety profile as far as, low capsular contracture rates, low infection rates. Being able to maintain your pec muscle in situ leads to a more anatomic breast implant placement, which is, underneath the fascia, underneath the breast tissue, leaving the muscle intact for patients who are worried about fitness or animation deformity. Not having the implants contract, move laterally can be of benefit to them, although it can't be 100% guaranteed. That would be, the biggest reason to do that. Or if patient has, a Poland syndrome or a condition where their pec muscles are not present, then you have no other choice to do that. That's, I've come across that. I think we all have as plastic surgeons, and you try to elevate the tissue that you can. And I think some of the results can be wonderful. And, it's really hard for me to tell whether it's sub-pec or above the muscle. The biggest downside, I would say, is visibility of the implant for thin patients. If you don't have that pinch test where you have some tissue to cover over that implant, despite being in the 5th or controversial 6th generation of implants, which may be an additional episode that we'll talk about, there still may be some ripple effect, some presence of an augmented or, done look. And then just the step off, if you have a chest wall and then you have an implant that's not underneath that muscle, I think that step off is going to be a little bit, or has the potential to be a little bit less natural slope. And there are ways to fix that, and that's including like fat grafting. So that's a common adjunct procedure where you can add fat into that area. You can try to decrease the bottoming out or that implant not being supported by the muscle over time and having it drop or sag more quickly by placing an internal bra. But all of a sudden you're, turning a breast augmentation into potentially a longer case with more adjunct procedures, adding fat, adding internal bra just because you want to try to preserve the muscle. So I think there's a little controversy or a little bit of decision-making. Ultimately, it needs to be a team decision between the patient and the surgeon, and what the surgeon is most comfortable in achieving in a safe way, in a reliable way, and in a consistent way. And there's not really a right or wrong. I think these are all great feasible options, and it's, should be patient-centric. Dan, anything for the above the muscle pros and cons that you want to add?
No, that really was spot on. I think, bottom line, you talk to your surgeon. It should be a conversation about goals, your lifestyle, making sure that it all matches up, and that you're not just jumping on what might seem like a trendy, or the alternative, what seems like what someone's always I've done this for 20 years. So, always trying to, learn and, be better to get better results, longer term results, and provide these different options for different patients to provide them what they're looking for. So I think Perfect. That's a great overview. Kept it a little shorter than our average, which is good. We'll hopefully keep adding some more of these kind of one-on-one conversations as well as we come up with more specific topics, like your case manager you're talking to. We kind of scratched the surface last season on just kind of broad overviews, but there's a lot of nuances within each of these that we can definitely get down into the details of. So great talk, and look forward to chatting again soon.
Yeah, plastic surgery, it's a wide world. There's so many topics. We love doing it. We're going to continue to bring in experts and talks, but I appreciate you bringing back and dropping the knowledge from your trip to Vegas, which sounded like it was very arduous, just a lot of learning going on. But thanks for bringing that back. And I agree, a great topic, very poignant and very timely, something that, we're getting more questions about. So hopefully the listeners were able to take home a few great concepts and clarify some of the more confusing parts of breast augmentation. So always great talking with you, and we'll see you soon.
All right. Have a good one.
Yep. Bye.
Thanks so much for tuning into this week's episode of Fuller Butz, a behind-the-scenes plastic surgery podcast. Doctors Fuller and Butz are so appreciative of your time and attention. We invite you to subscribe, share, and continue to enjoy our plastic surgery perspective. Feel free to reach out on Instagram at either @FullerSurgeryMD or @DanielButzMD. That's Butz with a Z, for comments, suggestions, and support. Remember, be artsy, stay scientific, and make life fun. We hope you'll join us again on the next episode of Fuller Butz.